Next section of Costanzo's respiratory physiology chapter, we're going to continue our discussion of ventilation-perfusion relationships. Remember, we talked about regional controls of ventilation, regional controls of perfusion, and now we're going to put some of that together. The ventilation perfusion, or VQ, is the ratio of alveolar ventilation to pulmonary blood flow. We need to match ventilation to perfusion to have ideal gas exchange. It doesn't make any sense for alveoli to be ventilated but not perfused, or for alveoli to be perfused but not ventilated. Normal ratio for VQ, averaged out over the entire lung, is 0.8. That means that the alveolar ventilation is 80% of the value of pulmonary blood flow. The term normal means that if your breathing frequency, tidal volume, and cardiac output are all normal, VQ will be about 0.8. If VQ is normal, then arterial O2 is normal at about 100, and arterial CO2 is normal at about 40. If for some reason we have a change in the VQ due to an alteration of alveolar ventilation, an alteration of pulmonary blood flow, or both, then gas exchange is less than ideal, and the values for arterial O2 and arterial CO2 can change. Figure 527 shows some of how these changes might play out. Figure 527 is on the top of page 221 in your text. So if our value of 0.8 is the average for the entire lung, it's really the fact that we have three different zones that are each contributing different VQ ratios and different arterial O2s and arterial CO2s leaving those regions. In zone 1, we've got the least blood flow, remember because of the hydrostatic effects of gravity. We have lower alveolar ventilation, but the changes in alveolar ventilation are not as great over the course of the lung. So the VQ ratio here is highest. Therefore, the arterial O2 is highest and the arterial CO2 is lowest. Let's compare this with zone 3, where the blood flow is highest. Alveolar ventilation is higher as well, but the difference in blood flow is much greater than the difference in alveolar ventilation. This produces a low V to Q ratio, and therefore a lower arterial O2 and a higher arterial CO2. Reviewing again, the regional variations in pulmonary blood flow are much greater than the regional variations in airflow. Zone 1 has the lowest blood flow, Zone 3's got the highest. The alveolar ventilation varies in the same direction, but less in magnitude. The ventilation effects can also be attributed to gravity in the upright lung. To think about how gravity produces differences in regional ventilation, imagine the lung as an accordion that is hung vertically. Between breaths, when we're at FRC, the weight of the accordion, the weight of the lung, squeezes air out of the bellows at the base, and most of the FRC fills the bellows at the apex. When the next breath is taken, most of the potential space where we can add air is at the base, where the apex is relatively full. But remember, regional variation in ventilation, not as great as regional ventilations in blood flow. So our VQ ratios are highest in zone 1, lowest in zone 3. They average for the whole lung around 0.8. Now, let's use figure 528 on page 222 to talk about the regional differences in ventilation to perfusion ratio and how these different arterial O2s and arterial CO2s are going to play out on the alveolar gas equation curve from early in the chapter. This is figure 5.5 repeated from earlier. Remember that the regional differences in arterial O2 are much greater than the regional differences in arterial CO2. In zone 1, where the VQ ratio is highest, we've got a relatively higher arterial oxygen content and a relatively lower arterial CO2. Compare this with zone 3, where our VQ is lowest. In this case, our arterial O2 is much lower, and our arterial CO2 is slightly higher. Zone 1, VQ is the highest, PaO2 is the highest, PaCO2 is the lowest. Zone 3, VQ is the lowest, PaO2 is lower, and PaCO2 is highest. We can average these regional differences for a healthy lung such that the blood leaving the lungs via the pulmonary vein, the sum of blood from all the zones, has an average arterial O2 of 100 and an average CO2 of 40, our normal arterial values. So, as we described previously, there's ventilation-perfusion matching. We want to ventilate alveoli that are close to perfused capillary. This arrangement will allow for the best possible gas exchange. And remember, despite the fact that there are regional variations in ventilation and perfusion, much more so for perfusion, the average value of the whole lung is about 0.8. We can continue this by looking at how mismatches of ventilation perfusion, called VQ defects, can be caused by ventilation of lung regions that are not perfused, dead space, or perfusion of lung regions that are not well ventilated, shunt, and every possible in between. This is shown in figures 529 and 530 on page 222 and 223. Many lung diseases exhibit the entire range of possible VQ defects. COPD is a good example of one. Here we've got regions of dead space where the ventilation is normal, but there's no perfusion, so the VQ ratio is 1/0 or infinity. We've got areas of high VQ, areas of low VQ, and then areas of shunt, where the perfusion is normal, but the ventilation is 0. So 0 over normal equals 0. Figure 530 then begins to assign some gases that would be in each of these theoretical VQ units. In the example of dead space, where VQ is infinity, we have ventilated lung that's not perfused. This ventilation is wasted or dead. It's just like air that we put in our trachea or conducting airways. Because no gas exchange is occurring, there's no blood flow to receive the oxygen from alveolar gas or to add CO2 to this alveolar gas. An example of this could be the dead space created by a pulmonary embolism, in which blood flow to a portion of the lung or the entire lung is occluded by a clot, usually migrating up from pelvic veins in the leg. In these areas of dead space, no gas exchange is occurring, so alveolar gas has the same composition as humidified-inspired air that we might find in the trachea. For example, an alveolar O2 of 150 and an alveolar CO2 of 0. No CO2 is coming back to these alveoli. We can also discuss regions of high ventilation perfusion matching. high VQ regions have high ventilation relative to perfusion, usually because the pulmonary blood flow is decreased to this region for some reason. As opposed to dead space where there's no perfusion, high VQ regions have some blood flow. Ventilation is high relative to perfusion, and the pulmonary capillary blood from these regions have a high O2 and a low PCO2. Regions with a low ventilation to perfusion index have low ventilation relative to perfusion, usually because the ventilation is decreased. Unlike shunt, where there's no ventilation, low VQ regions do have some. Because the ventilation is low relative to perfusion, the pulmonary capillary blood from these regions has a very low PO2 and a high PCO2. The final extreme is shunt, where VQ equals 0. Right to left shunt is perfusion of lung that's not ventilated. No gas exchange is occurring. Therefore, there's no ventilation to deliver oxygen to the blood or carry CO2 away. An example of the shunt is illustrated by airway obstruction, atelectasis, or by right to left cardiac shunts. Because no gas exchange is occurring with the shunt, the pulmonary capillary blood flow from these regions has the same composition as mixed venous blood, an arterial O2 of 40 and an arterial CO2 of 46. We can tell a patient has some component of shunt if we give 100% oxygen and this venous blood that's returning to the left heart and diluting the oxygenated blood can't be accounted for by increasing the oxygen of the inspired air. That